My name is Dr. Reshma Amin, and it's my absolute pleasure to be presenting this work on behalf of my team. Our work is titled Real-World Evidence for Canadian Neuromuscular Disease, establishing a framework for national integration of patient-reported outcomes, clinical registry data, healthcare utilization, and healthcare-associated costs. There are more than 7,000 genetic rare diseases in Canada, and at present, only a small number of those diseases have treatments. But these treatments are very expensive, and the number of treatments on the market is growing exponentially and holds real promise for diseases like Duchenne muscular dystrophy. However, there's important to know that there's information gaps related to these drugs and their high treatment costs, which is a real challenge for decision makers in Canada. And really, what's needed is real world data, which is data collected outside of the clinical trial paradigm, which includes things like registries, health administrative data, patient reported outcomes. And with the use of these, we can generate real world evidence and provide this evidence to regulatory bodies to really help provide data outside trial conditions to increase approval for these expensive drugs for an increased population of genetic conditions. One type of real-world data is health administrative data. And in Canada, we generate health administrative data at every single encounter that patients have with the healthcare system. And the data is collected for administrative or billing purposes, yet it can be leveraged to study healthcare delivery. And in Canada, we have provincial data holdings and we also have national data holdings. So we can study things at the national level and also the provincial level. But the challenge for diseases such as Duchenne muscular dystrophy is that the International Classification of Disease codes lump Duchenne muscular dystrophy with other muscular dystrophies, so you can't reliably identify which patients have Duchenne muscular dystrophy using health administrative databases alone. There's also not a specific drug that you can use that's only prescribed for DMD, and there's no validated algorithm. So the use of patient registries really is an asset to overcome some of these identification issues. And an example of a really robust registry in Canada is the Canadian Neuromuscular Disease Registry, which is really a global model for rare disease registries. And so our study aims, there were two. The first was to understand the burden of neuromuscular disease in the Canadian healthcare system, including the prevalence, healthcare utilization, direct costs, and health inequities. And second was to establish a platform for real world evidence generation for neuromuscular disease that can be used as a model for other rare diseases. We have two parts. The first was data linkage for a retrospective cohort. So here what we're doing is we're using patients identified by the Canadian Neuromuscular Disease Registry. We're linking those to health administrative data. This is going to be a national linkage with Statistics Canada and then a provincial linkage with 5 provinces. And we'll be able to get really robust details on acute healthcare service use, mortality, total healthcare use, and all publicly funded healthcare costs for Canadians living with spinal muscular atrophy and Duchenne muscular dystrophy. We chose to look at things nationally, so we have good representation across the country. And the 5 provinces that we've chosen to study are those who have sufficient provincial health administrative infrastructure. The second part is establishing a data platform for real-world evidence generation. So for this, we're setting up 4 prospective cohort studies in spinal muscular atrophy, Duchenne muscular dystrophy, spinal bulbar muscular atrophy, and oculopharyngeal muscular dystrophy. So cohorts that are really important for Canadians living with neuromuscular disease. And again here, we're going to now be linking patient-reported outcomes with neuromuscular disease registry data, as well as out-of-pocket costs. And we'll again have these robust linkages to get information now on patient-level details, so health-related quality of life, family-level details, so caregiver burden and mental health, mortality, healthcare service utilization, as well as publicly funded healthcare costs. So this work is underway currently, and our anticipated program impacts are that of a framework for rare disease linkage. We'll be able to validate the ICD-10 codes and future ICD-11 codes. We'll be able to inform health system decision makers on the variability in neuromuscular disease burden. We'll be able to build collaborative relationships with health administrative data researchers, both in Ontario as well as other provinces. We'll be establishing a platform for future cost effectiveness studies of disease modifying therapies. And really, this program of research will be an exemplar for other rare diseases to build real world evidence research programs. I really want to highlight my steering committee and the other co-principal investigators for this project, Victoria Hodgkinson, Hans Lockmuller, A.L. Cohen, Gord Jewett, and Homir Osman. Highlight our CNDR investigators, our NMD4C members, and our incredible team of patient partners, economists, and researchers. And finally, I really want to thank Defeat Duchenne Canada for their generous funding support to make this project possible. And with that, I will stop, and please feel free to reach out to me if you have any questions. Thank you so much.